Good morning, everyone. The meeting will start in a few, and wanted to disclose that the meeting is being recorded.
Good morning, everybody. Welcome to the CCO Operations Collaborative meeting. Looks like we still have a few people joining us. I'll give it another minute or so before we get started. Hey, good morning, everybody. This is the CCO Operations Collaborative meeting. I'm Dave Inbody, CCO Operations Director for OHA. And that's my dogs in the background. Sorry about that. Today, we have a number of items to cover for you. We will start with Nathan Roberts speaking on cognitive decline assessments. Then we'll get an update from Olive El-Rawi on the TNC pilot for NEMT. We'll spend a little time with Dana Carley to speak about our CCO enrollment capacity increases process and how that's going to be handled this year. And then we'll finish up with Jesse Wilson to touch on the HRSN climate-related supports feedback. We did plan to also discuss CCBHC today, but due to some scheduling challenges, we're going to push that out to April. So sorry about that. It might mean a slightly shorter meeting, but that being the case, ultimately we'll cover what we need to, and we'll be able to talk about that next month. One thing that I did want to touch on before we get started is the recent security event at Change Healthcare. I know many of you have heard about that. But I wanted to give some information, some updates. I know that we've been in touch with many, actually all of the CCOs about this, and we'll continue to work together to try and address this with the least amount of disruption. But just to give everybody a little bit of background, on February 21st, there was a security event that occurred at Change Healthcare's, in one of Change Healthcare's environments, their system basically. And once they recognized that there was a potential threat, they essentially disconnected their systems, which prevented some of the services in being processed. And just to let you know, the services, how they're being used is we send and receive pharmacy information between agencies and some of our OHP providers. So in shutting that down, you can recognize how that was a potential challenge that we'd be faced with. The CHC security team started working on that, and we believe that the issue is limited to just CHC. The OHP services, they remain operational, and so there's no impact to our networks or systems, and we'll continue to monitor that. Probably the best place for you to receive ongoing information is the CHC website in terms of what they're doing specifically. And if you wouldn't mind putting that in the chat, their website, I'd appreciate it. Yeah, go ahead, Jane. I see your hands raised.
So this also caused providers to not be able to submit claims. Many of our larger providers. Is there any thought to possibly extending the March 31st deadline so that any backlogged 2023 claims that we haven't been able to receive could be processed?
Yeah, we're examining that now.
Okay.
There are challenges in terms of our obligations to
Yeah,
the federal government, but yeah, I mean, we've had several CCOs contact us, and I totally understand why that would be a concern, because obviously the workarounds take much longer to process. But yeah, we should be able to give you a communication on that this week, ideally.
Thank you.
Yeah, thank you for asking. So just to give you an update on where CHC is now, what they've communicated most recently, they're anticipating, if all goes well, that their payment platform, the electronic payment functionality, will be returned on Friday, and that medical claims are going to begin testing next week, and are hoping to restore that within the week. But again, things change over time, but that's kind of what they're looking at right now. One of the things that, as this goes on, and this is where I appreciate the work of CCOs to try and manage this, is to the degree that there's identifications of workarounds. One of the things recommended by CHC was the use of their new claims submission system. And I know that some CCOs are looking at alternative clearinghouses. Some are accepting faxes and paper prescription submissions. Whatever you can do to try and ensure that the processes continue. I know that some of our smaller providers are seeing a financial crunch due to this, the delay in potential claims payments. So I know that some CCOs have offered initial payments in advance of confirmation, which that's something that's available to CCOs. But again, anything that you can do to help us continue to move forward with that would be appreciated. On our side, we're focused on trying to support our fee-for-service providers. Again, we've changed to another clearinghouse, and we're creating workarounds in a similar fashion. And I think as it becomes more clear, we'll be able to provide more information. At the federal level, CMS, the Center of Medicare and Medicaid Services, has provided some workarounds for Medicare. They haven't weighed in directly on Medicaid yet, but they're really looking to the states and the managed care plans to lead this effort. But they are definitely looking at what can be done as it relates to Medicaid. So hopefully we'll be getting new information from them on that. And I know that on a national level, the National Association of Medicaid Directors have also submitted to CMS requests for some flexibility around some of the requirements associated with Medicaid in light of this. So this is where we may be able to get some insight in terms of what flexibility might be made available. But again, I wanted to share that with you because it is an evolving story. It's something where we will continue to communicate this, but recognizing that at the heart of it, the critical aspect is to make sure that our members are still able to get their prescriptions and continue to be served, and that our providers are not put in undue financial straits. So thank you again for all of you that are doing. I know many of you are doing a variety of different things to try and smooth this out and work forward. So thank you for that. But just see if there's any questions before we move on. With that, let's see if we have Nathan Roberts with us.
Yes, I'm here.
There he is.
Hey.
Well, you're up. I'll let you tell us about cognitive decline assessments.
Yay! So I won't need 20 minutes. Apologize for not clarifying how much time I needed. So This is to just bring to your attention what we've actually already sent out to you in a memo on the memo is from February 13th. It's about a billing code 99483, which is for the assessment of and developing a care plan for cognitive decline, looking at dementia or that kind of signs. This came to our attention through the legislative process. There was actually a proposed legislation that would direct the health authority to cover this billing code. And when we saw the bill, we looked into it and determined that actually the health plan should already be covering this, that it wasn't something that we had intended to not cover. Our partners at HERC had already recommended that we cover it. We looked at all payers, all claims data, and many CCOs understood it to be covered from that HERC recommendation, and we're already covering this. The fee-for-service program was not, so there was definitely some inconsistencies across our system. So the memo went out to clarify that it is a covered service. We have corrected on our side, on the fee-for-service side. The code will show up on the fee-for-service fee schedule with this month's publication. We're due to publish an update to our fee schedule this month, so the code will show up covered there. I did get to go and testify at to the Senate Health and Behavior. I think, was it Senate or House? I don't remember. And the Alzheimer's Association of Oregon that had brought this forward also testified. And at that point, I did commit that we would share the word out that this is covered. And so the main reason I'm here is to make good on that commitment, that we would draw this to your attention. But again, many CCOs were already, if not all, were already covering this, and your technical folks got a memo from us and probably have already taken action on it as well. But Anne and crew, maybe we can get the memo attached to this meeting as well. I think we did that at QHawk yesterday. So happy to take any questions or open up for any discussion.
Any questions for Nathan? Yeah, go ahead, Deanne.
Yeah, just kind of a quick question around, do you see a particular difference between this specific code and assessment and the PASSARs?
So I actually don't know the PASSARs, and I don't know which billing code that might map to. But I would say in general, this shouldn't be treated any different than our other billing codes, right? The things that fit under that description are what's covered, and people need to use correct coding in that regard. If that helps, if you need more than that, I'm happy to research this a little bit further.
Oh,
but.
No, I don't want to take up your time. It was more of a
Okay.
curiosity, given the PASSARs are basically an assessment of cognition that the mental health providers have been doing, and
Okay.
often will go into nursing homes, et cetera, to provide that
Okay.
service. So I was just kind of trying to compare and contrast.
Comparing them. This code does include assessment and the care planning, so that it would also need to inclusive the time of developing that treatment plan or care plan to build this particular code.
Thank you.
And I'll forward the memo to you right now, and you can attach it. So.
Thank you.
Great, thank you, Nathan. Looks like we got Chris hand raised. Go ahead.
Yeah, so just a question about this code. I see it's on the diagnostic list already, so it would be covered as a diagnostic service. And if you already answered this question, I apologize, but is it on a fee schedule anywhere? It's not on the physical health fee schedule. I haven't checked the behavioral health.
It's not on any. It will with our March publication, which is coming out soon. So it will show up there, but it's not. It hasn't
On
been
behavioral
any
health
fee.
or on physical health?
I believe it will be on the physical health, the medical dental fee schedule. I believe. Yeah.
All right. Any other questions for Nathan? Okay. With that, thank you, Nathan.
Mhm.
Appreciate it. Our next item, we have Awab Alrawi with us, and he's going to give us an update as it relates to the TNC pilot for our NEMT. Awab.
Good morning, everyone. Thanks, Dave. I am hoping to give you this update as the last CCO Operations Collaborative update on the TNC pilot before it's activated and have TNCs participating in it. The most recent update on this is we finalized the rules and the application process and the certificate form. And we will be sharing those with the TNCs so that they could submit their applications. And once we have a determination by OHA to approve or not approve a TNC's application, then we can move forward and share with our CCOs and brokerages and just in mass communications that one TNC or more have been approved to operate under the TNC pilot, Transportation Network Companies pilot for the year 2024. So this is where we're at. I really appreciate your patience and your interest and engagement in this. It's been a long road to finalize the details of the pilot, and we're a little bit behind schedule, but we're hoping again that sometime by the end of this week to send communications to all CCOs in a memo to let you know that the application is now open and then we've reached out to the TNCs to apply. I will pause here and ask if there are any questions or any comments.
Any questions for Awab? I don't see any.
Sounds good. Well, thank you, everyone.
All right. Keep us posted. Appreciate it. Right. The next item that we have on the agenda for you is in relation to the member enrollment and CCO capacity limits. And I'll be turning it over to Dana, but just to let you know, I mean, as you're aware, there's been a period of time during the pandemic when we were managing our way around the fact that people were not being disenrolled from CCOs. And moving into this new time after the pandemic, we felt it important to share with you clarify the process of making changes to those enrollment limits. And Dana's here to talk us through that. And I appreciate you joining us, Dana. Turn it over to you.
Thank you, Dave. Can you hear me okay?
Yeah, I can hear you.
Oh, perfect. All right. Good morning, everyone. Thank you so much for sharing this time with me. I'm excited to talk to you a little bit about this project that I've been working on and hear your comments, questions, and suggestions. I do have the chat open so I can see if you have any questions or comments. So feel free to drop that in the chat or raise your hand. And then there'll be time at the end as well if you have any comments or questions. So today I'm going to be telling you a little bit more about how CCO account representatives work behind the scenes to address things like member enrollment and some of the problems that we've been running into with several plans exceeding their contracted capacity limits. So you're all familiar with this map of the CCO service area. So I'm not going to explain that. And in fact, I'm going to simplify it quite a bit. Next slide, Anne. Oh, can I move these slides? Thank you. So this is Tetra coordinated care. This is the CCO where math always works out without a calculator. And Tetra coordinated care has 3 counties, Moolock, Gramp, and Hoosier, and all of these are assigned their own capacity limits. Next slide. One of the roles of the CCO account representatives is taking that total capacity for each county and dividing it up into 5 enrollment levels. So our team likes to call these buckets, and you'll quickly see why. You can think of these buckets as the sort of space that's available to members, and the water is depicting the members that are filling up that space. Next slide. So if all goes according to plan, these members assign at the highest enrollment level that they're eligible for. Ideally, going all the way up to CCOA, or maybe if they're not quite eligible for that high enrollment level, they might be assigned at CCO B, E, G, or F. MMIS has the ability to roll members up into the highest level available to them. But if you go to the next slide. Next slide, please. Oh, go back one more. There it is. So what's not ideal is if the members get stuck because we don't have enough space available in that bucket. So if a bucket reaches capacity, enrollment becomes disabled, and that can force members into lower levels of enrollment or potentially out of CCO enrollment entirely. Those members end up staying fee for service. Oh, there's a delay. Okay, thanks, Anne. I appreciate that. So if the space is available, MMIS is pushing them up into these higher levels, but they might get stuck, or some of those levels might not be available for members at all. You can kind of see that CCOG where they get blocked off. All right, next slide. So what happens if we have more members than capacity? The CCO account representatives have some flexibility in terms of adjusting capacity within the county. So we can make the buckets bigger or smaller, and we are constantly monitoring each enrollment level and the enrollment capacity for each county to make sure that we have available slots for members. And we can't adjust the actual amount, the total capacity of 100. So what we're doing is we may be moving enrollment slots from one bucket to another. So in this example, we have only 3 members enrolled in CCOE, but we have 20 in CCOF. So we might want to make CCOF a larger bucket and take away space from CCOE. That way we can continue to see enrollment flowing between buckets. CCO account representatives monitor these on a weekly basis. So we might be making adjustments behind the scenes and making sure that enrollment continues to flow into each of these different enrollment levels. Next slide, please. We also are aware of some of the the flexibilities available in MMIS. So one of the things that MMIS allows automatically is overcapacity enrollment. You can see here where it will allow this, it'll allow enrollment to continue to 110% of capacity. And so we can use that flexibility to some degree to allow capacity enrollment to continue even if the county is already at capacity. So what we were doing largely during the pandemic was making sure that those adjustments were made so that we could continue getting members enrolled despite those contract limits. There are exceptions, and that's another flexibility that we're aware of, where there's, newborns will automatically assign to their mom's plan. MMIS will try to align members of the same household. That means they do a case alignment to make sure that everyone is on the same plan unless requested otherwise. We can also keep populations in the same, during region transfers, they will tend to stay in the same plan. I've added all these asterisks in here because it can vary quite a bit depending on things like if they're in the same contract. So we do have a couple plans that have separate contracts for different regions, and that may not necessarily count as a region transfer. We also try to keep members back in the same CCOs that they were enrolled with previously. So if a member, was enrolled with a CCO, say Tetra coordinated care, and they lost enrollment because maybe they didn't keep up with their eligibility, and then that member reapplies for OHP, MMIS will look back on their prior CCO enrollment and try to enroll them with the same plan. Now, that may not always occur, especially if there's other circumstances such as a move to another county, or if that enrollment happened a very, very long time ago, MMIS may not necessarily assign at that time. Next slide, please. Once we hit 120%, no auto assignment is going to take place and manual enrollment becomes disabled. So we have some ability to manually enroll members above 110%, and that can be done for particular populations where we're trying to, say, keep the families together, or they have a special request. But once we hit 120%, we have to do a lot more tinkering behind the scenes to get MMIS to open back that enrollment and allow the member to get in. Now, the thing to keep in mind about this is it's only the one county that is above capacity that would be closed. So there could be one county within a plan that is close to a new enrollment.
I don't know, can you? Say hi.
Sorry, what was that? Was that a question? All right. So some of these counties may be still open to enrollment, but the one county that is over capacity is not able to take new enrollments. Next slide, please. The other thing that we cannot do, and I think if you go forward one more, that'll show a little block there. We cannot move from one county to another. So even though we can move within those buckets within one county and adjust the capacity for CCO A, B, G, E, and F, we cannot just take membership enrollment out of another county and put it into one that needs more membership. So that is set to the contract capacity limit. Next slide. So as Dave touched upon at the beginning of the presentation, during the pandemic, we had a lot of enrollment waivers that allowed us to continue enrolling members into CCOs despite the capacity or the contract limits. What we would essentially be doing is monitoring that CCO enrollment, and then as we started reaching above 100%, getting to about 105%, we would be adjusting the total capacity to make sure that enrollment could continue. So this way we were making sure that as many members as possible were being served during the pandemic and people weren't being locked out of CCOs just because of the contract capacity limits. So you probably got emails about once every quarter or so letting you know that we were going to continue expanding that waiver. Next slide. So now we don't have that capacity enrollment waiver, and we've been noticing that our member enrollment has been dropping slower than we had predicted. A lot of members, I believe it's about around 85% right now, are retaining some level of eligibility for OHP. So what this means is that we also have a number of new legislative changes that have allowed more members to have access to CCO enrollment. And not all of them will have full CCO enrollment, such as CCO A, which covers physical, behavioral, and dental care. But we do see quite a bit of members who are eligible for CCO F. So they're eligible for dental and behavioral health care or dental only care. When we started 2024, we were aware that a number of CCOs had already essentially surpassed their enrollment limitations for that for their contract. So we've still been having to keep a close eye on these CCOs, as well as others that are kind of on the border of hitting those limits. Unfortunately, because we don't have the waiver now, we are limited in that we can't necessarily make those capacity limits bigger. So even though we have more members coming in, we don't have the ability to make them bigger. So there are two possible scenarios that I'm really interested in hearing your feedback on, and this is the process that we're working on developing to make sure that we're addressing this particular issue. So one, if the CCO would like to increase capacity, or if the CCO wants to stay the same and doesn't have the capacity to have more members enrolled. Next slide, please. So ideally, the best situation for us and for members is that CCOs feel like they do have the capacity to serve more members. We would love to be able to offer that kind of expansion and make sure that more members have access to CCO services rather than getting trapped in lower levels of care or ending up without CCO enrollment at all. We know there's a number of benefits that CCOs offer that is not necessarily available through fee-for-service, and so we want to maximize that ability for members as much as possible. So some of the things that we want to hear more about from you is if you want to make a request to increase your capacity, how would you prefer to make those requests? You know, on one hand, we can keep things very low tech and keep them into emails or to the account representatives or perhaps other staff. We could also formalize it through an online form or fillable PDF, something that would be captured in a document that you all could save as well. What information would be useful to make a determination? Some of the things that we might be looking at is, does the CCO have the capacity to serve the members based on things like provider availability? Are they struggling to serve members already? Or is it just a matter of increasing the numbers on paper because you already have the ability to do so? We're also really aware that you submit a number of reports regularly and you're tracking tons of data. And so we want to make this process as simple as possible rather than burdening your staff with requests and workload that goes beyond what you have been asked to do already. So one of the ways that we can do that is by trying to look at existing data or existing reports that are already being submitted so that we can make those assessments without necessarily asking for more data from you. We may not necessarily always be able to approve a request to increase. So one of the things that I'd like to know what your thoughts are is, you know, if we have to deny a request for an increase, what might be the ramifications to members? What might be a reason for doing so? What other concerns might we have that would impact whether CCOs can take on additional membership or whether or not they need to get a little additional support before they're able to increase that capacity? And then what else is out there? What other thoughts do you have? What concerns, what questions, what are your needs in terms of requesting an increase to your capacity? The more concerning one is if we cannot increase capacity. So we have had situations in the past where we've had to close panels to new enrollment. And essentially what that means is that new members who are trying to enroll into the plan or would be eligible for CCO enrollment don't have that ability until the panel becomes open again. We have had population exceptions. As I mentioned before, members who are newborns always assigned to their mom's plan. You know, we try to keep family members together. We may have other flexibility here that we can select certain populations or needs where those members will stay together rather than lose CCO enrollment. Sometimes we've had closures where they've been temporary, so the county is closed for a few months and then gets reopened for enrollment. And this just kind of allows that enrollment flow to slow down to a trickle rather than that steady stream that we're seeing. If we have to close one of those panels, we want to know how are we going to make those, how are we going to communicate that? And not just to the CCOs, but to all of the enrollment and member facing teams. So how are our client enrollment services teams going to communicate that a CCO is not available to them? How will your staff be talking to members if they're calling up your CCO wondering why they can't get enrollment? We can also look at possibilities such as if members are able to enroll into another CCO. So some regions do have multiple CCOs serving those counties, and some CCOs are the only CCO in that entire county. So one of the possibilities may be that, you know, if there's CCOs serving multiple counties, or if there's multiple CCOs in a county, we may be able to just move that member into a different CCO. Alternatively, perhaps we could look into other options where members could request enrollment into CCOs in alternative counties where they may be accessing care already. Go ahead to the next slide. There's also questions such as when can they be reopened for enrollment? What might we do for urgent requests or re-enrollment requests? We also need to make sure that we're not missing out on certain populations. So our Heritage Native American populations are members who have third-party liability. They may not necessarily auto-enroll into CCOs, or they may not have the higher levels of CCO enrollment, and that could end up creating equity issues in which certain populations may be less likely to have CCO access than others. We also have certain populations such as our Oregon Youth Authority members, child welfare members, adults and people with disabilities, where they have caseworkers or eligibility staff who are helping with those enrollments, and they may be able to get into CCOs a little bit easier than members who have to make those requests through client enrollment services. Are there other concerns or thoughts that y'all have about these particular questions, or are there other questions that you think that we should be looking at? You can go to the next slide, Anne. So currently, we've already kind of completed the problem definition, which is just looking at what our barriers and challenges are. We've been talking to different teams about what might be possible and what might not be. For this month, I'm talking to quite a few people trying to figure out, what's possible with our contracts, what's possible from CCOs. And this is where I'd really like to get your feedback and your input on what's important to you, particularly in areas such as if you want to increase your capacity, how do you prefer to do that? How would you like to submit information? How would you like to communicate with your staff? How would you like to hear about those decisions? So I will be taking feedback through March 22nd. And then that last week of March, I'll be finalizing that process for us, reviewing it with our teams internally, developing some of those communication materials that we need available, and then sharing that back out with everybody who's been involved. Phase 4, hopefully by the first week of April, we'll be able to be taking those requests for capacity increases, and then for the rest of the year, be able to monitor and increase capacity or address the capacity issues as needed. Go ahead to the next slide. So what questions do you have?
Any questions for Dana? Yeah, go ahead, Jane.
I'm just wondering, are you going to have work groups to obtain the feedback, or do you want us to just submit based on the questions you have in your slides? What's the plan?
If people are interested, I would love to set up a meeting with a work group or two. I have my email. It looks like Anne posted it in the chat, and also on the last slide, my email is right there. You can also give me a call, and I will set up something for all of you to share your feedback. But you can also just get in touch with me via email if that works best for you.
Thank you.
Dana, do you have any preference on who CCOs may want to participate in that work group? What type of background, or where you want to focus that discussion?
I would recommend having your enrollment staff, if you have staff who are tracking your enrollment numbers, your provider availability. If you have possibly your contracts or complaints and grievances team, that may be useful to provide feedback. It kind of depends on what kind of information we end up collecting, but definitely anybody who is tracking your member enrollment and monitoring your overall capacity would be useful. And I think a contracts administrator would be useful as well. Good question.
Any other questions or comments for Dana?
Thank you so much for your time. I look forward to hearing from you.
Great. Thank you, Dana, and looking forward to where this takes us. I appreciate everyone's involvement in advance. Definitely an important thing to work through, and looking forward to where it leads us. Thank you, Dana. The next item that we have is in relation to the HRSN climate related supports. I think we're a little early, so I don't know. Jesse Wilson, are you with us? I don't know if Jesse's with us yet. In the interim, I know that Mary Durant has an update for us as it relates to 834s and the impact of one update. So Mary, do you want to give us some information about that?
Absolutely. Thanks, Dave. Good morning, everybody. Many of you may have noticed that at the end of February, you received a rather large daily 834, and the timing was a bit confusing because the size seemed more like a monthly file, but the content was a daily file. So we did some research and determined that that was based on some one changes that were happening with regard to renewal dates. And that is a process that's going to be happening once a month through November. So each month towards the very end of the month, you will be receiving a quite large daily file that comes before the monthly file, but in a similar time frame. So we just wanted to give you the heads up that that's going to be happening. I'll be mentioning at this month's All Plan System Technical as well for the folks maybe that are a little closer to processing those files. But just a heads up, every month towards the end of the month through November, you will get a large daily file.
Yeah, Jane?
Mary, is there any way we can get advance notice of when that file's going to drop? Because it does create, I mean, it takes quite a bit to process that file.
Yeah, I can definitely.
Scheduled.
I think I have the dates. I'm waiting for confirmation because I don't want to be wrong. So I can definitely share that out through this group and then also at All Plan. It does look, we have the March date already. It's going to be March 29th. And it looks like it will be 2 days before the end of the month each month. So a 30-day month would be the 28th. A 31-day month would be the 29th. But I just want to make sure I have final confirmation of that. So I'll share it out for sure.
Thank you.
Any other questions for Mary? Jane, is that your hand again, or is that from the original question there?
Sorry, I was trying to drop it.
Okay. All right. Thank you, Mary. Oh, go ahead, Sheila.
Sorry, I was double muted. Can you hear me okay?
Yeah, I can hear you.
Yes.
Go ahead.
Okay. Hi, Mary. It's Sheila. I was just wondering, is that file expected to be as large as the one we just received each month?
My understanding is yes. I'm not exactly positive. I'm trying to work through what all's coming through those changes, but I definitely think that they could all be that large. Yes.
Okay. Thank you.
Yes.
right. Let's see if Veronica Guerra's joined us. Are you with us, Veronica? I know she's jumping between meetings here, so
I am here.
every minute. Oh,
I
there
do
she
see
is.
a hand up, Dave. I don't know if we.
Oh, Sheila, I don't know if that's the same question or if you have another question for us.
No. Okay.
Oh,
All
there
right,
you go.
I will go
Okay.
ahead. And apologies, I don't have a slide here, but this is related to the care coordination memo that Dave had up on the original slide with the agenda. Wanted to just kind of provide some clarification about the memo that went out on February 28th to the CCOs. We during contracts and compliance and also in separate through some separate communications, there were several questions from many of you about the upcoming care coordination report that would have been due on March 1st of this year. And we clarified in the memo that was sent out on February 28th, posted to the contract forms page, contract announcements section, that we were going to be deferring that specific care coordination report. So the content of the care coordination report, as you all previously had submitted it, was going to be tabled, and we were going to be deferring the submission of that specific report. In its stead, we are planning to have you all submit, so as a replacement, we would have request that you all submit your risk stratification methodology. And what we are hoping is that that will be kind of our initial opportunity to look at and talk through the risk stratification methodology together. And kind of give you some feedback. My team is currently working on putting together a model methodology, and we hope to be able to distribute that probably by the end of this month to the CCOs. And so we'll have the opportunity to kind of convene together with you all. We plan to, it was stated in the memo, but we plan to reconvene the CCO work group that contributed and provided feedback to the rulemaking process. And so that group will be reconvened. We will look at the model risk methodology together and make additional, revisions to that model document. And then the hope is that we will be using the work group process basically to kind of refine your draft risk stratification methodologies that you've all been working on and have developed. And we will send another memo out once we have identified the due date for the final, so the submission of that risk stratification methodology. So the memo states that we will give you the full 90 days once the final model is determined. So once OHA has our final model based on the feedback we received from you all during the CCO care coordination work group, then we will finalize it and send out the due date for that risk stratification methodology that has to be submitted to OHA for approval. The goal of this whole process is to make sure that we are ensuring there's some level of standardization across CCOs so that we have, we don't have any differences in terms of populations that maybe are accounted differently in across the three risk categories that we've developed. So we want to make sure that we have some consistency and standardization across all CCOs in terms of who ends up in that high risk category versus the medium risk and then the low risk category. So with that said, I will stop talking and see if there are any questions or comments.
Do you have an idea of when that meeting will, when the invites will go out for that work group?
Yeah. Once the draft methodology goes out at the end of this month, we'll probably be convening at some point in March. Sorry, this is March, in April. We'll be reaching out soon. I would say probably within the next week, week and a half, to the folks that previously participated in the work group to get some initial doodle polls out there to try to identify a time for April. Or a few times for April. I think we'll definitely need more than one meeting. I see a hand up.
Michael.
I saw Michael.
And I just want to make sure that we're clear on kind of the final once that OHA convenes and gets the feedback from the CCOs. Is it that the model or the methodology is going to come from OHA, that the CCOs still need to put in their logic based on that methodology, or is it going to be the same for all CCOs?
That you will have the opportunity to make revisions to your own methodology based on the model. And we can work through kind of, during the work group, what I think it's we'll have to work through some of those kind of questions, because I would be interested in understanding where maybe there are differences between the model and your individual, draft methodologies. But yeah, the short answer is that, you will have the opportunity to modify based on what comes out in the model.
Thanks, Veronica.
Let's see more. I see something in the chat. Are there clinicians at OHA participating in that risk stratification methodology? We don't have our medical director participating, but we do have one of our new managers on the quality assurance team, who is a nurse, that she will be participating in the risk methodology development process on the OHA side. And she has some robust experience at the hospital level, kind of doing this work. And there's Leslie. Thank you, Leslie, for coming on camera. And I think as we kind of move forward, it probably would behoove us to kind of plug in our medical director, Dawn Montner, and any other folks on her team that maybe want to participate in that process. So thank you, Marcy, for that question. Any other questions or comments? All right. And just to reiterate, we will communicate via memo when we have that due date finalized. But everyone who's involved in the work group will be made aware, obviously, well in advance of that. That's it, Dave. Handing it back to you.
Right. Thank you, Veronica. And as I mentioned, had a couple of adjustments to the agenda. We do have one item left. We wanted to spend some time on, actually, it's happening in real time. I'm going to see if we may actually be able to get Jesse Wilson earlier to present to you on the waiver in relation to climate. Let me see. If you can give me just a moment, we'll see if we can make that work for us. Okay, it looks like Jesse's actually going to be able to join us, so we'll be able to move forward with the agenda once she jumps on. Appreciate your patience. And there she is now.
Good
Jessie.
morning, folks.
Morning.
Yeah,
Thank
thanks
you
for
for
having
joining
me.
us. I appreciate you
Absolutely.
making adjustments to your schedule to join us. But so we're going to turn over to you. You have some things to share with us about the waiver and some climate information. So I'll turn it over to you, Jessie.
Thanks, Dave. Good morning, folks. Just wanted to do a check-in with y'all on how the climate-related supports is going since the launch on the 1st of the month. Just doing an informal check with you, and I wanted to talk through some discussion questions here and gather some initial feedback. So really open up to the audience here. If you want to put something in the chat or raise your hand, just looking to, again, hear how it's going so far since the 12 days that this benefit has been live. So first question, what is going well since the HRSN climate related supports launch? So opening it up here, folks, what is going well since this has gone live on the 1st? And as you're thinking about that, go through the other questions here in case you want to kind of cover them all in a response. But also curious about if you've ordered any climate devices yet, if you're willing to share how many, and then also talking about were these orders the result of you doing the CCO doing proactive outreach, or did members find out about the benefit and they contacted you specifically? Curious about how that's working. And then if you've had any denials for HRSN, are the devices able to go out via HRS? And then happy to hear any challenges you're experiencing related to this as well. If we need to continue to problem solve anything to support members getting the devices. So looking for feedback and what you have to say on these 3 questions. Yeah, Dave.
Go ahead, Dave.
What's going well is that it's actually working. So a lot of kind of quick build once we got those final service protocols. Thanks to all of your efforts to really give us a lot of knowledge before that. So it made it pretty smooth. Still lots of things to work on though. We have ordered several climate devices. I think we're in the double digits at this point. They are right now not a result necessarily of proactive outreach. They're a result of kind of combining our workflows between HRS flex funds and the benefit. But I think we'll start to see more and more as we're able to both communicate and start that proactive outreach process. No denials yet, but our policy is to, if they don't meet HRSN requirements, to shift them to our flex process. So that will happen, I'm sure. And the challenges are just to continue to fine tune the process in time to develop, to bring our primary focus to the housing and food benefits. So trying to get the climate all sorted so that we're ready for the next go live on November 1st.
Awesome. Thanks so much, Dave. I have a quick follow-up question for you. So you haven't had any denials yet, but have you thought through the process when you do, if a member is denied for HRSN services, what that communication is going to look like? Because I know that several CCOs have expressed concerns about there being confusion if they're denied for HRSN, but then you provide it through HRS. Have you thought about that workflow and how you're going to help avoid confusion?
Yeah, we're finalizing that letter right now to essentially go through this flow of, we are going to be providing you an air conditioner or an air filter, and then lower in the letter say, you didn't qualify for this particular benefit, but again, reassure them that an air conditioner whatever is on its way. So I think it's about, we're trying to structure our denial level so that the first thing they see isn't you were denied for this under the HRSN, and then maybe they stop reading and then an air conditioner shows up. So that's how we're trying to work through it and meet the kind of timing and workflow requirements in the service protocols.
Great. Thanks so much for providing that info.
Dave, just so for those who may not have had the opportunity to meet you yet, can you tell us which CCO you're from, what area of the state that is?
I'm so sorry. Yes, so I represent Care Oregon's social health team, and so that includes Jackson Care Connect, Columbia Pacific, and a portion of HealthStream membership.
Great, thank you.
Any other CCOs with any feedback on how it's going so far? Okay, well, we will be reaching out to all the CCOs after April 1st. I'll send out an email to informally collect some feedback, similar to what I just went through here. Really going to seek that information for the 30 days of post-implementation to collect some of this feedback. I see, Michael, you have your hand up, so I'll pause.
Yes, thanks, Jess. I'm not sure if there was a response yet, but one of the questions that we had from Cascade Health Alliance was about if there was any updates to the documentation or the templates yet for CCO submitting the claims. So if we're doing the work and not using a partner, which we do with the climate, similar to what Dave was covering, because since it's not an MMIS yet.
Yeah, thanks for that, Michael. I saw your email, and I wonder if Chelsea Guest is on and wants to talk about the template a little bit. If not, we can follow up with everyone offline. Is Chelsea on?
I don't think Chelsea's with us.
Okay. Yeah, so the MMIS change request to implement the service-based payments, that is not live yet. That won't be live till later this summer. And so there's a template that we sent out a link to, and I think Chelsea sent out the link a couple weeks ago, but I'll follow up on that and provide some clarity on that process.
Great. Thanks, Jesse. Appreciate that.
Mm-hmm. Okay, let's go. I think I have one more slide, and I just wanted to touch on some resources. So we've been gradually adding additional resources to the website. I sent out an email to CCOs, to the CEOs and the contract contacts and compliance officers and innovator agents. Sent out an email on the 1st of March with some initial resources, and then sent out an update last weekend with what we've added since then. But we do have a waiver webpage, and we also have an HRSN specific webpage that has some more information. And then the climate benefit webpage has some documents that may be helpful. We've created a fact sheet that's available in 7 languages that really collects like just kind of a 2-pager of what is the benefit, who's eligible, how can you start the process to receive the devices, and who you can contact. And then we have a frequently asked question document that's also available in 7 languages. And that's really a collection of a lot of questions we received either from CCOs or from partners or even members as well in our different engagements. Just try to collect all of the questions that might come up from individuals and the responses there. So check those out. Those are live on the webpage. We also have an HRSN outreach and engagement fact sheet. Several questions around outreach and engagement of what is it, who is eligible, what are the activities that are included, how can providers be compensated for these services. So that fact sheet is available in English. We're working on a Spanish translation as well, and that will be updated as soon as possible. We also have some forms, and I know CCOs had asked about these forms in the work session. So we have the HRSN request form. It's a PDF fillable version. So you're welcome to use that or members are welcome to use that to self-refer for climate devices. Providers can use that as well. We are working on getting that in other languages as well, and that should be up very soon. So I'll send out an update as soon as we have that. The information sharing authorization form is also there as well. And then we have the fee schedule, which has all of the rates for the climate devices, and that also includes the outreach and engagement as well. And then we have a waiver newsletter. So continuing to provide updates on these resources. But if you have questions or need something else that's not listed, please let me know. Last week in my email, I sent out a comparison version of the January guidance document and the February guidance document, because that was requested. How did we change? What did we update in the guidance document in the latest version? So that went out last week, as well as an ICD-10 crosswalk document for the clinical risk criteria. So let me know if you have any questions on those resources. And I think that's it, Dave.
Great. Well, thank you for joining us. Thank you for being flexible with the timing, and especially thank you to you and your team for all the hard work here. It's exciting this coming out, so we'll see over the next several months as this evolves. So thank you very much.
Thanks for having me.
All right. With that, we've come to the end of our agenda. I want to see if anybody has any questions, comments, any other things that they'd like to bring up before we close. If not, thank you for your time. I appreciate it. And we'll see you again very soon. Take care.